Okay, welcome to this continuing education webinar. The title of this education is Dry Eye Disease, Current and Emerging Novel Tear Stimulating Therapies for Improved Outcomes. So I'm Dr. Guyman, and then later will be Dr. Donnenfeld. We're here together, so we're going to be kind of going over different aspects of this uh, webinar, this continuing education. And this is supported by Oyster Point Pharma. So yeah, so just a few housekeeping items. We're going to go through a few slides and then I'll kind of get right into the education here. But this one's an important one. If you want your certificates, make sure that to receive them, ensure that you attend the entire webinar, afterwards complete the brief evaluation, and then download your certificate using the link provided at the conclusion of the program. So you have 6 months to do this, so should be plenty of time, but make sure you do that to get credit. And then here are the disclosures, disclaimers for both of us here. Now, the main learning objectives for this webinar, there's kind of a two-pronged approach here. So first, we're going to summarize the pathophysiology and contributing factors to dry eye disease. And so we'll go over main things that cause or dry eyes and some contributing factors. And then Dr. Donnenfeld will actually get into more specifics and detailed clinical real-world evidence surrounding some of these new treatments that are coming out or are kind of fairly new that have been out. And so to get started, or sorry, here's the agenda. So we're each going to have a test question or a question at the beginning of our lecture here. And then at the end, we'll kind of go over that same question and give you the right answer here. So let's do that. So I'll kind of go over my question here. This is a case here, a 50-year-old female patient presents with symptoms of chronic dry eye disease and seasonal allergic conjunctivitis. The patient reports persistent ocular discomfort, redness, itching, worse during allergy season. And then upon examination, there's definitely inflammation on the ocular surface there. And the patient has a history and has current borderline high eye pressures. And this patient's also been known to be a steroid responder in the past with eye pressure spikes. And so even though the steroid eye drops help significantly with her symptoms, given the patient's condition and concerns, which of the following new or emerging treatments could be best to alleviate symptoms and reduce inflammation, similar to how a steroid eye drop helped her in the past? So then she could potentially use this drop, possibly long-term, possibly without any of the risks associated with steroid eye drops. And so here's a few of the answers that we're going to actually go over. And right here, you'll actually be able to, we'll do a poll to see kind of what your guesses might be here. And these are all upcoming medications that will be coming out soon that we're going to kind of go over. And a few of them that I'm actually really excited about here. Okay. I'm going to move on here because we're going to go over this here and again. All right. So yeah, like I said, so I'm Dr. Neil Guyman, and I'm in a group practice in Idaho Falls, Idaho. And a lot of what I do, I kind of host a YouTube education. We do educational content about eye conditions, a lot of dry eye disease that is on there. And so this was kind of right up my alley, but I'm going to mostly go over and discuss the pathophysiology and factors contributing to dry eye disease. And then I'll kind of briefly mention some of those medications, new medications, and in-office procedures, and then let Dr. Donnenfeld kind of go into more detail and clinical studies on that. Yeah, more disclosures here. Okay, so now a lot of this might be a review here, and we hear this a lot, that dry eye disease is considered a multifactorial condition. So meaning there are a million and one different causes or things that contribute to someone having dry eyes. But what you really break it down to is whatever is going to disrupt the tear film and ocular surface. So you're supposed to have this perfect concoction of a tear. So this is your lipid, aqueous, mucin layers. And if something gets disrupted there, then you can get into this dry eye cycle. Now, usually when you're talking about the core mechanism of dry eyes, usually this word will be thrown out, and that's what's called hyperosmolarity. So your tears have a certain salt concentration to it, and if something gets disrupted, so you have more tears that get evaporated, or you don't have enough tears, but as these tears are evaporated, it leaves behind salt that raises the salt concentration of your tears, has hyperosmolarity. The salty tears can actually cause damage to the ocular surface. This causes inflammation, and the inflammation amplifies this hyperosmolarity, and that's where this vicious cycle comes in. And so people will have those dry eye symptoms like redness and irritation, fluctuating blurry vision, ocular surface damage, foreign body sensation. And so that's where people enter that vicious cycle here. Now, usually when we're also talking about dry eye, we're we usually kind of break them down into three different categories. Now, there are more niche dry eye or types of dry eye, but the main ones are definitely aqueous deficient. Eyes aren't producing enough tears or enough of the water, aqueous portion of the tears. And then a big one is evaporative dry eye, where your tears are evaporating too fast majority of this time, and it's 80% of the people that have evaporative dry eye usually have a condition or something going wrong with their meibomian glands. They have meibomian gland dysfunction. And so big portion of people with dry eyes have evaporative dry eye due to something with the meibomian glands. And so you'll see a lot of this treatment and in-office procedures target the meibomian glands, trying to get those functioning better and helping out the tear structure that way. And then a lot of people will have mixed conditions, evaporative, aqueous, mixed condition. Like I said, there are many multifactorial conditions that can cause dry eye. A lot of times people say there's 99 causes of dry eye on the wall or a million and one causes of dry eyes. Now I put this link in the slides here. This is probably one of the better lists of causes of dry eyes that I've seen. It's not a dryeye.org. They have, I think it's like 68 maybe on there, and then a link to that goes into more specifics about those causes. So it's kind of a nice list that you can refer to. There were a few things that they didn't mention, which I'll go over here. One that can contribute to dry eyes is actually the preservatives that are in eye drop medications. So a big one is glaucoma medication. So pressure lowering eye drops. A lot of them will actually have a preservative in there, and it's usually the common one is BAC, benzalkonium chloride. That's kind of the famous preservative known for causing eye irritation, and sometimes some people are more sensitive, maybe allergic to this type of preservative. And so sometimes you have those glaucoma patients that are using the drops where they're getting severe redness and dryness and inflammation from using that drop, and it's because maybe that preservative is contributing or causing that vicious cycle of dryness there. And you'll also find them find these preservatives in artificial tear. So patients will use artificial tear drops, and sometimes the preservatives will actually contribute to the dry eyes. And so it's counterproductive there. And so I actually put up a list of different eye drops, artificial tears, and their preservatives in there. I need to find an updated list because there's many more artificial tears, over-the-counter ones that have come out that have been great. So I need to update that list. But also I put some of the glaucoma medications in there. Also, this needs to be updated too because there's a lot of other ones with different preservatives and preservative-free options there. But yeah, so that's usually why you'll have eye doctors that are steering patients towards doing preservative-free artificial tears or preservative-free eye drops just to try and avoid contributing to dry eyes that way when we're trying to actually fix the solutions, fix the situation there. Another one it doesn't really talk about in that list that I want to go over is post-surgery dryness. Now, this can be from refractive surgery, big one is LASIK there, but also can be from cataract surgery as well. And this can stem from just the eye drops, the prescription drops that you're given for the procedure. This can be your antibiotic, steroid eye drops, sometimes the artificial tears, but sometimes the medication itself, maybe the antibiotic might be a little bit disruptive to the ocular surface and cause people to get into that cycle of dryness there, or it could be the preservatives in the drops as well. And so, yeah, you'll find people that are doing LASIK or cataract surgery and start knowing, hey, my eyes are, getting dry for sure. Another one specifically with LASIK is that you can actually get that nerve damage. So when they actually do the procedure and cut those nerves, that cuts out the feedback loop that the brain gets to know if the eyes are dry, to pump more tears out. And so people's tear production definitely drops after LASIK, and then they get into that cycle of dryness. Now, usually these nerves grow back. They usually grow back within 6 months, can take longer, but you'll definitely have some patients that report of having more of a chronic, long-term dry eyes after having LASIK surgery or refractive surgery. And it might be, due to the nerves, how they grew back. And sometimes it can be really bad, it can be painful. Sometimes people develop neurotrophic keratitis also from it. Now, this also can happen from cataract surgery, definitely more rare. But the reason why I put up this picture right here, I actually did a video about it, about cataract surgery and dry eye. It was actually starting to become one of the most common questions and comments I was getting on some of my other YouTube videos. And so, yeah, so I actually asked Dr. Michelle Lee to actually collaborate with me, and we could answer some of those questions. But so it's more common to me just because I was getting all those comments, but yeah, so it's something to be aware of there. A few other things that we want to talk about that definitely contribute. One is hormones with menopause. Women over 50, studies show twice as likely to have a dry eye condition or dry eye disease over men. Usually this is from menopause or the decrease in those hormones. Now, it's interesting, and I really don't think I knew this from school. Maybe I did, but in the meibomian glands, they actually have receptors to these sex hormones. And so when you have a decrease in these sex hormones, androgen, estrogen, then you will have less production of oil or meibum from the meibomian glands. The meibomian glands might not actually function that well. And so you'll get evaporative dry eye. And so this is one thing to know. If you have a patient, female patient over 50, getting more dry eyes, it could, in menopause, could be from this. And what's tricky is if you put them on a hormone replacement therapy or supplements, depending on what they get, sometimes certain ones can actually, the replacement therapy can actually cause dry eyes. And so can be a tightrope walk with hormones and treatment for dry eyes. But yeah, a lot of times these women will need extra help there. And definitely one to mention is autoimmune diseases. Big one that a lot of people associate eye dryness with is Sjogren's syndrome. This is where it will attack the salivary glands, so you get a dry mouth, and then the lacrimal glands, so you get a dry eye. And yeah, this person, I put a picture on there, will usually have some dry eyes, ocular surface irritation, keratitis. Some people might get filaments that get stuck on the cornea that you have to remove. So that's kind of a big one. Usually people have to get tested to see if they have Sjogren's there. Rheumatoid arthritis. Studies show 20 to 30%. I was just reading some studies preparing for this. Some were saying up to 40% of the people that have rheumatoid arthritis will probably have a dry eye condition with it just from that inflammation. So that's good to be aware of. Thyroid eye disease, Graves' disease, inflammation, or if it's bad where they have the proptosis, they'll get more exposure and evaporative dry eye that way as well. And then lupus has the inflammation, but there's also a link with lupus and Sjogren's. Up to about 20%, could be more, of the people that have lupus also have Sjogren's with it. And so they usually will have dryness as well. Now, I'm going to go over briefly, so some of the current and emerging treatments. I'll kind of do like the intro to the new prescriptions that are coming out. And like I said, Dr. Donenfeld will go over kind of more in depth. And then I'll go over some of the in-office procedures that are kind of becoming more popular and an option in a lot of offices that you can offer to patients. So starting with one of probably the longest prescription eye drops that have been out there is Restasis. It's a cyclosporin, works as a kind of an anti-inflammatory to that lacrimal gland. It helps increase tear production. Tricky parts with this here, with Restasis, Cequa, or now the generic Restasis, is that it can take several weeks, 6 weeks, months to see the benefit from it. And so you just kind of have to have that patient keep going to know if it's going to work. Uh, Over the last few years, we've been able to have Xiidra with lifitegrast, also works as an anti-inflammatory, um, and has been FDA approved for signs and symptoms for dry eyes, which has been nice and has worked a little faster. They say it can work, or you'll see benefits up to 2 weeks. Usually it's about a month for me on that one. So it works a little faster. And now a new prescription that just came out last year is VEVI, um, which is pretty much a higher concentration of cyclosporin, about double Restasis, water-free, still twice a day, but they've kind of changed the vehicle so it can access the cornea, get to the cornea faster and better. So you'll get faster results. I think they say 2 weeks, usually see significant improvement with dry eyes on this one. MyBo has been a unique drop been about a year and a half. Pretty much creates or helps function as a lipid layer over the tears to help with evaporative dry eye. I've had patients on this and have done really well. A lot of times after uh, cataract surgery, it seems like MyBo has been a great drop for that if they're kind of experiencing dryness. The thing about this, you might have patients that come in because they've been doing like advertisements with MyBo, and so they've heard about this drop. But you'll have some patients that have also heard that you can get the same drop in the UK or Australia, and this is where it's not a prescription over there. It's usually cheaper. So you have some patients that have been buying it over there and shipping it here and getting it cheaper without a prescription. Uh, and they tried to stop that. And so I don't know, it's a whole ordeal. So you might have a patient that has heard about this, or they might be mad about the price of MyBo and might be searching this out. And so, yeah, these are the same drops. So Evo Tears, Novo Tears, UK and Australia, I think is how it goes. And I think there's a couple other ones too. But so yeah, just be aware, patient might know about that. So a novel way of treating dry eyes is neurostimulation. Been around for a few years. But this is to stimulate the trigeminal nerve branch by your nose. And this is kind of considered a backdoor dry eye treatment. So it actually stimulates that trigeminal nerve that stimulates the nasolacrimal reflex that tells your eyes to produce more basal tears. So this is your baseline tears. And what's nice about your basal tears is that it has uh, all the structures of the tears. It has the lipid, aqueous, mucin, and so basal tears are really nice if you can increase those. And so the big one, probably the one that most people do here is Tyrvaya. It's a nasal spray that stimulates that nerve. There's also a mechanical stimulator, iTear 100, kind of vibrates on the outside of the nose. I've actually used both of these. It works really well. Um, Super weird, but it actually works great. But it's nice. The nice thing about these is that it's not another eye drop. It's not another eye medication. It's something different, and so a lot of people might actually like this. Okay, so one of the newer medications that are coming out, Coltramin, and I might be pronouncing these wrong. I usually do until it actually comes out and I start hearing the correct pronunciation. Maybe Dr. Donenfeld will correct me on these, but Coltramin, the unique thing about this one will be they'll activate the thermoreceptors of the eye, so the cold receptors that actually tells the eyes to produce more basal tears as well. So this will have a kind of a cooling effect on the eye. So I'm kind of curious and definitely want to try this one out. This will be an interesting one. This one's coming out this year. I think they have it, oh yeah, next month, so May 30th there. So that one's going to be really soon. Reproxalap, this one is definitely going to be unique type of drop. It's marketed it as an anti-inflammatory, and how they're marketing it and structuring it is they're actually going to say, hey, this is designed for people with dry eyes, chronic allergies, allergic conjunctivitis, and uveitis. And they're saying this can be an alternative to a steroid eye drop. So those patients that have uh, we're worried about eye pressure or side effects of steroids or long-term steroid eye drop use, then this might be the go-to to use in its place where you can possibly use it long term and not have those side effects like steroids. And so I'm really excited to have see how this one works out. It was supposed to come out, I think, last week or a couple weeks ago, I think. But I think they had to resubmit an FDA approval. They needed another study or something, I think was what I was reading. I'm guessing it's going to come out really soon, but this, yeah, they had to push back a little bit. This one I've been hearing about, ST100, is a type of an eye drop that is a collagen mimetic. So it will repair damaged collagen, restore structure in the matrix of the cornea, can help with the inflammation, dry eyes, and could potentially help with corneal nerves, so restore corneal nerves. So that's really exciting, kind of in the docket there. This one also going to be exciting, AZR-MD001. uh, the words. This one can be unique as well. So like I said, a lot of people have meibomian gland dysfunction, and one of those causes could be an overproduction of abnormal keratin that gets over those meibomian glands and clogs it and blocks it up. And so this is actually a cream that you'll be able to put on there that can, kind of slow down that production, break up that keratin, and help the meibomian glands function better. If you notice, this is actually selenium sulfide, so it's kind of the same stuff that's in Selsun Blue, the anti-dandruff shampoo. But yeah, this will be, cream for the eyes, obviously. But yeah. XDEMVY been out for a while. Dr. Donenfeld's going to go over this as well. This has worked really well as an eye drop for people that have Demodex blepharitis. So mites in there causes the inflammation. The inflammation triggers that cycle of dry eye. So this isn't really a dry eye drop. It's more of a Demodex blepharitis drop, but it treats the cause of the dry eyes kind of thing. I've used this on quite a few patients and actually works really well. Yeah, so kind of transitioning into in-office procedures. So this is someone with rosacea, ocular rosacea, where the XDEMVY could help. And from what I've heard is they're actually developing a cream that might help with the rosacea as well if it's caused by Demodex. But yeah, there are in-office procedures, and we'll go over that are becoming more popular to be offered in clinics here. One that you've heard of, probably the most popular right now, is called IPL, or intense pulsed light. So this helps treat that ocular rosacea, can help treat Demodex blepharitis, styes, overall dry eyes, inflammation, and it mainly works by using photocoagulation. So if you see someone with blepharitis or you see those tiny blood vessels, the telangiectasia, this can actually photocoagulate those. And pretty much what you're doing is you are destroying the highway or the access point for inflammation that goes through those tiny blood vessels and gets leached out and leaked out into the meibomian glands and the eyelids, contributing to that inflammation. So you kind of break off that highway access there. It can heat up the meibomian glands. Can be tricky if it gets enough heat to actually help get that oil out, but it can do that, and it can kill little microorganisms. So this has worked really well. We had this in our clinic, and yeah, I did a video on it as well, but a lot of patients have liked this one. It's been a good option. One that is building up steam is red light therapy. So this is the umbrella term is photobiomodulation, or low level light therapy is what we'll kind of use in the clinic. And they are finding that red light and near infrared light can help with collagen production, can help with inflammation, can work on all skin types, can help treat the upper eyelid a little bit better. With IPL, it can be iffy, treating that upper eyelid, and can help with lacrimal gland tear production. And the reason why this is kind of gaining steam is because there was a red eye or a red light therapy device that was actually FDA approved for macular degeneration as a treatment there to kind of slow down intermediate macular degeneration there. And so you're finding some uh, ophthalmologists, retinal specialists that are bringing in red light therapy to their offices for macular degeneration. And so, yeah, this is kind of more gaining more buzz on this one here. You'll get a lot of questions from patients if they ask this because there's a lot of the over-the-counter red light therapy products, and they're like, hey, can I just buy this one off Amazon? And that it gets tricky because it's kind of a developing field here. The biggest difference there is you're talking about the power output. A lot of those products that you get on Amazon, they'd have to be in front of that red eye device for like 10 hours a day. And so it might not be the best here. So that's like the biggest difference between home products and in-office products is the power output, and so the effective treatment that you can get there. Meibomian gland expression. A lot of eye doctors will do this, so maybe we'll do some kind of thermal treatment on those oil glands to heat them up and express that oil, clean out the rancid old oil that's in there. Or if you have keratin or blocked oil glands, there is meibomian gland probing, where they actually take a probe and just open up a hole or break up that keratin to make it so the oil can actually be released from those oil glands there. Rinsada, this one is fairly new. And when I heard about it, I almost brushed it off because I kind of looked at it as hey, just a fancy way to flush the eye. Maybe just kind of the same thing if you lift the eyelid up and squirt some eyelid wash up at the top eyelid. But they have actually done studies to show that with this device, because you can effectively rinse out that superior fornix and the inferior one, you can actually decrease MMP9, that's the inflammation marker cells there, by 70% on the ocular surface. So that number kind of surprised me. So it does rinse the eye, but the main thing is actually will get rid of or uh, decrease those inflammation built up MMP9s that might be sitting up in the superior fornix that might be causing that cycle of dry eyes. And so this can be a low cost option for the office and the patient here if you're seeing a lot of inflammation, maybe tear film debris and buildups that's in there. And so might be something, or that maybe they wear a lot of makeup and wonder if there's a lot of makeup buildup. So it might be a good option just to offer that. Punctal plugs, I know, been around for a long time. The reason why I put this one in here is because there was a new type of plug that was a cyclosporin-loaded plug that was in the works, where over a 6-month time, as that plug would dissolve, it actually released cyclosporin onto the surface of the eye and help with that inflammation. But as of now, it's not in the dry eye pipelines. On the website, it's not really there anymore. So I don't know if it's been discontinued. I think it has, but I don't know the details there. Maybe one of you know more than I do. But there was a little bit of an exciting one, but yeah, might not be coming out anymore. And then there is a kind of the evolution of punctal plugs. This is Lacrophil, which is a gel that you can actually put into that punctum, and it blocks it really well and can dissolve, or you can have people come back and you actually irrigate that out. I think Dr. Donenfeld's going to talk about this too. And then amniotic membranes, been out for a while as well. The kind of big one's been this ProCare. That's that big ring one right there in that picture. But there's been these and dehydrated membranes. They go under the umbrella of biologics, where that you can actually apply it to the surface of the eye. And this is for someone that maybe has neurotrophic keratitis or a neurotrophic ulcer, an ulcer that's just not really healing up for whatever reason. It's just staying there no matter what drops or dry eye treatments or anything that you put on there. This is a really good option for that, to actually provide and stimulate self-healing to that corneal surface, and it works really well. It can help with inflammation and scarring and generate some more healing factors in there. It can be antimicrobial, so it can be really good. Um, they just came out with the CAM 360. So this is biotissue, the same people that do Procera. We just got this in our office, so I haven't even tried it on a patient, but it's a type of a membrane that you can apply on the contact lens or a corneal shield, and you can put it on the surface, kind of like Procera without that big membrane. This is more for the mild to moderate neurotrophic keratitis or those ulcers there. But hopefully this can be more comfortable to the patient and work really well. And here's some resources that I put in there if you want to kind of look into more of the what's in the pipeline for dry eyes. Um, but yeah, thank you. I'm going to go over that question again and kind of give you the answer on that one. So hopefully it'll be a little bit more obvious here. So we have that 50-year-old female patient that presented to the office with dry eye disease and seasonal allergies, with all the symptoms there. Definitely has inflammation on the ocular surface. Now, this is a patient that has had borderline and has borderline high eye pressures and is known to be a steroid eye responder. So when she takes steroids, that pressure will spike and she'll kind of have that side effect there. Even though the steroid works well, that's something that you're trying to avoid. So the question is, uh, what is a possible new eye drop or treatment that's coming out that can alleviate these symptoms, reduce inflammation, similar to the steroid eye drop, but not have the possible long-term effects that are associated with a steroid eye drop. And that one, the one that's coming out really soon, is um, uh, reproxalap. I don't know if I was supposed to give you time to answer that, but but it's A. Yeah, close that out. Okay, so that is it for me. Uh, all right, 87%. There we go. Nice job. That was good. So yeah, that's it for me. Like I said, we're going to turn the time over to Dr. Donenfeld that's going to go over more details, clinical results and statistics there of these new medications there. So I'm going to stop my screen and let him take over.
Well, I think that was a superb overview by Dr. Guyman, and we're going to continue that story about dry eye right now. I think it's an extraordinarily important story to tell, and you heard a lot about many new technologies that I find extremely exciting today. And let's start my story with a pre-test clinical vignette. And this is a case that just came to me a couple of months ago, actually. And it's a 51-year-old female who had intractable itching and was extremely unhappy. I mean, this patient was incapacitated by her itching. She had a history of cat allergy, has been diagnosed by dry eye, staph blepharitis, meibomianitis. She's seen ophthalmologists, optometrists, an allergist. She's been prescribed cyclosporin, lifitegrast, numerous corticosteroids, artificial tears, antihistamines, has not had relief, and she is at her wit's end right now. So she walks in to see me, and I examine her, and her vision is good. She does have 2+ meibomian gland dysfunction. She's got some thickened secretions. Her conjunctiva is injected. Her cornea is clear. And we did meibography on her. And here you can see the meibography up top there. You see a fairly normal meibography. On the bottom, you can see that she has what's called constipated meibomian glands. They're thickened and they're widened and they're foreshortened. This is chronic meibomian gland dysfunction. But she's been treated for meibomian gland disease, and she really hasn't gotten better. So we had to do that old special test of just looking down. And there it is, hiding in plain sight, classic Demodex blepharitis. So Demodex has been a real interest of mine for decades. My partner, Hank Perry, might be the world's expert on Demodex. And for decades, we considered this to be a commensal organism that really did no harm. And it reminds me of that famous Mark Twain quotation. Mark Twain said it best: "It's not what you don't know that gets in trouble, but it's what you know for certain that just ain't so that gets you in trouble." And we thought that meibomian gland disease, had no relation at all to Demodex. We thought Demodex really didn't do any harm at all. So that was an error that we believed in for a long time. And the second part of the story that we believed was that itching was always allergy. And the take-home message that I've learned is that Demodex does cause itching, and the itching between allergy and Demodex is a very different type of itching. With allergy, the eye will be red, the eye will be itchy. With Demodex, it's almost always the lid margin. The patient will actually take their finger and rub it against the side of their eye and show you exactly on the lid where it itches, just the way this woman was doing. This was Demodex blepharitis, and we treated her for her Demodex blepharitis. We used Xdemvy, and the patient responded beautifully. So the question I have for you here today is the diagnosis of Demodex. Do you need to pluck a lash like my partner Hank Perry does and observe it under a microscope? Do you have to have meibomian gland inspissation to have Demodex? Are collarettes on the base of the eyelash pathognomonic? Or is itching pathognomonic of Demodex blepharitis? Okay, let's take your pretest. Let's see what we have here. So the majority of you say, 61% say collarettes on the base of the eyelash is what you need. 26% of you want to see it under a microscope. I like that. And meibomian gland inspissation is seen in 13% of patients. So great. Let's go on to our talk now, and we'll come back to this post-test later on, and we'll have some answers for you. So this talk is entitled Dry Eye Disease, Current and Emerging Novel Therapies. I've been very fortunate in my career in that I've been very involved in dry eye. I'm a very busy surgeon. I'm arguably the busiest surgeon in the Northeast of the United States. I do a lot of cataract surgery, LASIK. I was on the FDA trials for LASIK for a number of different cataract IOLs. But my teacher at Wills Eye Hospital, Peter Laibson, said, "Eric, take care of the little things and the big things will take care of themselves." And he said, "Eric, you should really concentrate on dry eye." And that's always been an extraordinary part of my career. I was one of the lead investigators with Restasis or cyclosporin in 2000, and that really changed everything. For the first time, we had a drug that really could treat dry eye. Before, we just basically thought dry eye was an involutional aging change that we had no control over, and you treated it with tears, and the patient just went on to suffer, and there was nothing that could be done about it. For the first time, we knew that dry eye was really related to inflammation, and we had a therapy that could actually be fairly effective against this disease. That really changed everything in the world of dry eye. So with that in mind, let's go look at a couple of emerging therapies and a couple of therapies that are basically in an FDA trial. Let's see, I'm trying to advance. There we go. Here's my conflict of interest. It's a little embarrassing, but I do consult with almost every company in the dry eye space, and I've been involved in a lot of FDA trials with these companies as well. So I start my talk by saying something very simple, and that is the tear film is the most important refracting surface of the eye. Why is that important? It's important because quality vision starts with a healthy tear film, and all the advances we've had in technology in the last 20 years are lost with even minimal disruption. So phaco, multifocal lenses, LASIK, contact lens wear are all diminished greatly when the ocular surface is not good. So for visual rehabilitation, everything starts with the tear film. The current therapeutic targets we have are numerous. We just used to have inflammation when we had restasis. We've added a couple other anti-inflammatories like lifitegrast, which is Xiidra. We have numerous cyclosporin molecules now, and we have loteprednol itabenate, Isufis, which is actually approved for dry eye flares. We find loteprednol to be a very effective drug, probably one of the most effective drugs that we have. We have neuromodulation, as you heard before, Tyrvaya neuromodulates. You can you can reduce tear evaporation with MIBO, anti-inflammatory effects. So the disease is a complex disease, and there are multiple therapies, some upstream, some downstream. So what are the new therapies for dry eye that have been recently approved? And I think these are the ones that I want to concentrate on before we go to the drugs that are coming. This is perfluorohexyloctane. Say that 3 times fast. This is MIBO, approved in May of 2023. MIBO has become my easy button. You know, when you that old Staples advertisement where you push the button, it says that was easy. This is my easy button. And the reason for that is it works extraordinarily quickly, it works effectively, and it has almost no complications. The side effect profile is less than 1%, which is, 10% of what the other dry eye therapies are. It's a class of drugs called semifluorinated alkanes, as we heard before from Dr. Guyman. It's available internationally. It's dosed 4 times a day. It's a water-free molecule. And you have to be careful with this molecule. It's a small bottle, and people look at it and say, wow, I paid a lot of money for that very small bottle. But the drops are 1/4 the size of a normal bottle. So when you apply it, make sure you only put 1 drop in, because you can easily put in 10 or 15 drops at once and not know it, because not only is the drop small, but it's extraordinarily comfortable. There's no burning, irritation. You don't even feel it's there. Sometimes I'll tell patients to put it in the refrigerator to cool it off, so you can have a cooling effect and feel it that way. It's approved to treat the signs and symptoms of dry eye, and it really does a wonderful job of treating dry eye. The only downside to it is it doesn't treat the cause of the dry eye. So this is a drug that addresses the symptoms, but doesn't address the cause of the dry eye. It doesn't treat the underlying meibomian gland dysfunction or aqueous deficiency dry eye that's seen here as well. And here are the FDA trials, Gobi and Mojave. We were part of these, and you can see here that it improved everything. The endpoint was 57 days, but that was a primary endpoint, but the secondary endpoint was 2 weeks, and it had dramatic FDA approval, significance at 2 weeks, which is really extraordinary. You don't really see that with most dry eye products. So it targets dry eye by supporting the meibum layer, restricting evaporations, and I find it to be very effective and easy to use. You heard a little bit about lotilaner, Xdemvy, for the treatment of dry eye. And it's not approved for dry eye, it's approved for blepharitis, but I view Demodex as kind of the missing link in dry eye. It kind of bridges that gap on why patients have meibomian gland disease. And what you're seeing here is a disease, Demodex, in which the Demodex mite is found in the meibomian glands, and it causes inflammation. It leaves body parts, excrement, irritation that causes a lot of ocular surface disease. And for the first time, we have an FDA-approved drug for this. It's a multi-dose bottle. Lotilaner is used twice a day for 6 weeks. It paralyzes and kills the mites. And the collarettes are really the key here. What we found is that the collarettes are absolutely pathognomonic of the finding of Demodex. And if you see collarettes, you know you have your diagnosis. Here are the clinical trials. You have the Saturn 1 and the Saturn 2, and you have combined pivotal data. You see here that there's a 50% reduction in collarette complete cure at 6 weeks versus 10% for the controls. You can see mite eradication is dramatically increased, and safety is great. As a side effect of the medication, which is something that patients really have embraced, is that lid erythema is markedly decreased. So a lot of patients who have Demodex will walk around chronically with red eyes. They look like they've been drinking. They walk into the office. they're using their anti-dry eye medications, and they're using their whitening medications like Lumify. And they go on this medication, they find that their eyes turn white. And that's been one of the nicer effects of using this medication. Complete cure. A follow-up study showed that most patients who got lotilaner had a efficacy that lasted for a year. So the 6-week therapy lasts for a full year. And my experience has been that we're seeing patients now that are coming back after a year of having been on therapy, and we're treating them for a second time as well, and they're doing very effectively with this. Another thing that was very nice is that this is a drug from a company called Tarsus, and I should mention Mibo as well, which is from Bausch and Lomb. They've gone to specialty pharmacies, and they made it very easy to get. We don't get the callbacks anymore. We send a note to the specialty pharmacy, and they handle all the problems, and we don't have to worry about our staff being overwhelmed with callbacks. Okay, a new cyclosporin, Vivi, is from Harrow. This is a cyclosporin with twice the concentration that Restasis has, as Dr. Guyman mentioned. It was approved in June of 2023. We're almost approaching 2 years now. I find it to be very effective, and it's effective not only because it has a cyclosporine, but it has a vehicle of perfluorobutylpentane. It's a semi-fluorinated alkane, similar in some ways to Mibo. And you look at the FDA trials here and you say, wow, that's pretty amazing that 56% of the patients showed improvement at 2 weeks out with the Vivi. But you look at the control group, which got just the vehicle, and here you see 47% had improvement. So obviously the vehicle is playing a very significant role here in the improvement. So it's comfortable, again, small drops. The patients respond to it very nicely. And at 1 month, 66% of patients had improvement. And again, remarkably, if you look at corneal staining here, corneal staining has improved dramatically very early in the management of these patients. Again, another therapy that I like very much. I'm the head of the advisory board for Nordic, which is the company that provides this new lacrimal filler called Lacrofill. And this has really changed a lot of what I do. And this has become a very primary therapy for me right now. I don't think we do enough punctal occlusion right now. And the take-home message here is that all canalicular systems and punctum are not the same. So when you put a punctal plug in, sometimes it fits loosely, sometimes it fits tightly. What's nice about this is a form-fitting cross-linked hyaluronic acid that fits right into the punctum. You just basically inject it into the punctum at the slit lamp, use a topical anesthetic, and this lasts for about 6 months. It can be irrigated out if you want to, and very commonly they'll wrap around and close the superior punctum as well, which is very, very nice. It really improves dry eye very dramatically. And if we look at the trials that we're about to publish, you see here that versus a hydrogel plug, you can see here at month 3 and month 6, there was a improvement in the dry eye scores in these patients. Excuse me. So here's the ocular surface disease index, which is a very common index we use for managing dry eye. And you can see here that the patients who got Lacrofill, 56% had an improvement in their OSDI at 3 months and 51% at 6 months again. Of course, fluorescein staining was dramatically reduced and tear breakup time was improved. So I find this to be a very helpful drug for dry eye. And we're doing a study right now, and I'm of a belief that in addition to occluding the punctum, I think that the cross-linked hyaluronic acid may leach out slowly and provide a continued source of tears in the eye, with hyaluronic acid being probably the most effective tear that we use on a routine basis. So I think it may just be more than a punctal occlusion. I think you actually may be getting a therapeutic effect from the hyaluronic acid as well. I love this therapy, and I'll ask Dr. Guyman about this later on. But we do a lot of co-management with optometry, and I'm encouraging our referring optometrists to consider in any patient with any ocular surface disease before referring for cataract or for LASIK surgery to consider doing lacrimal fill on these patients, in that when they come to us, their ocular surfaces are markedly improved, their uh, topographic analysis are better. We get better keratometry on our cataract surgery. So this is something where I think optometry and ophthalmology can work together very nicely to improve patient management. Emerging therapies for dry eye, well, we've got a lot of them. You saw this before. This is selenium sulfide. It's basically a dandruff shampoo to the lid margin. Nice thing about this, it's twice a week. At bedtime, it's a little ointment. And in a lot of patients who have meibomian gland disease, they have hyperkeratinization that blocks the glands. The studies have really shown some very nice improvement in the keratin removal. It basically opens up the lids and allows the meibomian glands to express themselves much more easily. It's very easy to use, and it's in phase 3 trials right now. And here you can see the blocked glands that you see in patients with meibomian gland dysfunction, and the um, uh, selenium-based shampoo allows these to be opened up and prevents the obstruction of the meibomian glands. Phase 2 results are excellent, with significant signs and symptoms improvement. There's kind of a new lexicon here and new names that you have to get used to, and the main outcomes were change in meibomian gland function, and they actually would look for expressibility of the meibomian glands, whether they expressed themselves easily or whether they didn't, and what the meibomian gland secretions looked like. Again, showing marked improvement here as well. Reproxalap is a RASP inhibitor. It's a novel investigational therapy that targets reactive aldehyde species. It's currently being evaluated for dry eye disease by a company called Aldira, and AbbVie, which used to be Allergan, has the rights to this molecule and is investigating it as well. And they just had a phase 3 trial, I believe, that was turned down by the FDA, which sounds bad, but not. This is the norm for dry eye disease. It's very hard to get a dry eye drug approved. As a matter of fact, Restasis was turned down 5 times before it was approved by the FDA. But I'm very confident that this drug will be approved. And what's nice about this is it's a new pathway. We've got a lot of pathways that look at inflammation, but RAS inhibitors are kind of on the top of the cascade of inflammation, actually before corticosteroids, before cytokines, before cyclosporin and lifitegrast. And for that reason, it may be a more potent medication, and it's again a new pathway, and these new pathways are something that I think we should embrace, and we'll be learning a lot about them in the very near future. The primary endpoints for the RAS inhibitor, reproxalap, was Schirmer test on day 1 in a dry eye chamber. And you see here that 25% of patients had a greater than 10 millimeter increase in their Schirmer scores with reproxalap versus 8% for the vehicle. So this was a very highly statistically significant improvement, and something that we've seen on repeated analysis. Melanocortin agonism is a new mechanism of action. Melanocortin receptors are expressed on immune cells. They shift the cells from pro-inflammatory to a resolution state. And this is available systemically for other diseases right now. And it's being looked at very excited to look at this new medication. Again, this just had an FDA trial that was turned down by the FDA. But again, I feel very confident that it will be approved in the near future. And again, it's a novel pathway, something brand new that we haven't looked at before. And in the MELODY trials, multiple secondary symptoms were significantly improved, and there was excellent tolerability and safety. And you always have to worry about that with dry eye, is that if a drug works, it's great, but if it's not tolerated well, it's not going to be nearly as effective. One of the most interesting new drugs that's entering FDA trials is OCS-02 from a company called Oculus. Again, I'm the chair of the medical advisory board of this company as well. And this is an antibody fragment. It's a single chain fragment that inhibits inflammatory cytokine TNF alpha, tissue necrosis factor alpha. Um, it's interesting in ophthalmology and optometry, we're about 15 years behind what's happening systemically. When you look at anti-inflammatory therapies like cyclosporin, they were available 15 years before we had it available in eye care. Uh, TNF alpha is the main source of anti-inflammatory therapies right now systemically, and there are a number of billion-dollar drugs that are available systemically for treating inflammatory systemic disease, things like um, arthritis and Crohn's disease, for example. And this is the first time it's ever been formulated as an eye drop. It binds to human TNF alpha, and in the trials, this is a phase 2 trial. The change in discomfort was statistically significant versus vehicle. But what makes it really even more exciting is that there may be a genetic predisposition, and for the first time, we may have a drug that targets patients with certain genotypes. And this is kind of the future of medicine. We're going to be looking at smart therapies, therapies that are dedicated for individuals. So when a patient walks into your office, you're going to do some genetic markers on the patient, and you're going to find out whether or not, and you're going to know whether or not the patient's going to respond to these therapies. And here you see, it's called a SNP. It's a genetic marker. And 20% of Europeans and 13% of African Americans have this SNP. And these patients had a very dramatic improvement in their dry eye signs and symptoms, overwhelming improvement. And again, the smart medicine, I think, is going to be the future of dry eye management. Um, it has a very nice effect on dry eye. Positive trials and the phase 3 trials right now just closed, and we're looking for those improvements. Very quickly, oxygenate German is formulating a drop for dry eye as well. And that's, we don't have a lot of information on that right now, but that's coming down the pipeline as well. And then finally, I want to close with a new drop that's probably the next drug that will be approved by the FDA. That's a Cultramin from Alcon. It's an ophthalmic solution, and it's a first-in-class novel pathway as well. One of the great mysteries of science is why we have our basal secretion of tears. Why do tears secrete, and why do our eyes stay moist, even in different environments? You know, you can be out in a desert, you can be indoors. It doesn't matter, your tears secrete routinely. It's not reflex tearing that does that, it's basal tear secretion. And this mystery was discovered a few years back, and the people who discovered this found out that we have a novel pathway that looks at our basal tear secretion. And the people who did this actually won the Nobel Prize. And they found this new receptor called TRPM8 receptors, or cold thermosensory neurons. So we all know that if you feel cold, you actually feel the cold, and those are reflex tear responses. So if you have a blast of cold air out, you'll have tears, but you'll feel cold. What actually produces basal tears is cold receptors that will identify 0.1 degree centigrade change in temperature. And these cold thermosensory neurons are expressed with the TRPM8 channels, which respond to mild ocular cooling and produce basal tears. So by stimulating this pathway, you can stimulate not reflex tears, like if you're gonna cut an onion, you'll get reflex tearing. This is basal tears. And the nice thing about basal tears, it's not only the aqueous tears, it's also the meibomian glands that are being secreted as well. So it really secretes all forms of dry eye. This persistent stimulation of the basal tear production may lead to ocular surface inflammation. By activating TRPM8, you really can improve things dramatically. And this is kind of the crazy part of the trials, is that 50% of the patients in the trials got Schirmer scores that increased by 10 millimeters or more, which is an amazing number. one of the side effects of the TRPM8 pathway, it's called the it's called a menthol receptor, is that patients will say, I feel like a menthol feel in the eye. Some people feel it's soothing, they'll notice it. But when you look at the FDA trials, you'll have a lot of patients will say that they noticed that feeling. That feeling lasts for less than a minute. It's not burning or irritation, but in the FDA trials, these patients didn't have a choice and they put it down as burning or irritation. So it's very well tolerated. Almost no one in this trials discontinued the medication, but uh, if you look at the trials, there'll be a lot of patients who noted to have this irritation, but the irritation wasn't significant. It actually, many patients thought it felt good, and no one discontinued the medication. So a very exciting drug that'll probably be approved this year in the next few months. So that's my summary of some new drugs. Let's go back to our pretest now. Clinical vignette number 2, again, the 51-year-old female who's at her wit's end. She's seen 9 different doctors, ophthalmologists, optometrists, allergists. She's been prescribed cyclosporin. She has Demodex blepharitis and meibomian gland dysfunction. And the question that we're asking again is, how do you make the diagnosis of Demodex blepharitis? Do you make it based on visible mites, meibomian gland inspissation, collarettes on the base of the eyelash, or itching of the eye? Let's take our post-test now and see how we did. Okay, and here we go. So collarettes, we went from 61% to 71%. I think that's the right answer that we should be looking at here. But yes, if you want to be a scientist and look under the microscope for Demodex mites, I have no problem with that at all. So with that, I'm going to close that study. I'm going to stop sharing. And Dr. Guyman and I can now answer questions. We have a few questions to answer. Okay, let's go. Neil, you with us?
Here we go. Yeah. Just had
All
to
right,
get
why
my
don't you
video
handle the
back.
first question?
Okay, so first question, let's see. I think it's, yeah, what is your maintenance treatment for patients with Demodex blepharitis? Is it hypochlorous lid spray, Oust tea tree oil, lid wipes? Is that the, am I seeing this right? Is that the same? Okay. So yeah, maintenance treatment. So this, if we're kind of considering someone that maybe started Xdemvy, a treatment, and hey, we did well, treatment went well. Is there a maintenance thing that we can do? Um, yeah, so eyelid hygiene, definitely a big one, and tea tree oil that's in these wipes or eyelid washes, or Manuka honey has been shown to actually help with mites. Hypochlorous acid spray, I think they can help, but I think it just targets the nymph stage of the Demodex, so it can help, but might not work as well. Is that right? Is that what you'd say?
Yeah, I like that response. When a patient has Demodex blepharitis, we have an FDA-approved product that's better tolerated and more effective than anything else that's out there. So I like to go to Xdemvy.
Yeah.
When they recur, I go back to Xdemvy. The only time I don't use lotilaner, which is Xdemvy, is when the patient has an insurance issue and it doesn't cover it, and that does happen. So, what's your backup plan if a patient comes back and say, "Hey, they want to charge me $1,000 for Xdemvy"? Well, there I like tea tree oil, and there's a very nice lid wipe that I like, Neil, called Optase tea tree oil. It's a
Yeah.
little wipe. It has tea tree oil on it, and I just have the patient close their eyes and I rub it along the lids. Now, there are a lot of other therapies, like you mentioned, but that's kind of become my go-to backup plan for patients who need additional therapy, usually due to insurance coverage. And that, again, it's Optase tea tree oil. Do it twice a day for 6 weeks.
Yeah, I've actually tried a few of those wipes, and the Optase is the one that I definitely liked for sure. Here, let me just read this next one here. Which pharmacy do you like to send Mibo to? Local, BlinkRx, other mail order pharmacy. So BlinkRx, I've had the best success. Local pharmacy. I'm trying to remember if I've been able to do it at a local pharmacy. It just seems like BlinkRx works the best, but That
Yeah,
could just be me.
I agree with you. CVS has a plan that sometimes works well also. They have a special relationship with some of these companies as well.
Oh
Uh,
yeah.
my,
Okay.
my problem though is if you send it to a regular pharmacy, very commonly I find the medications get switched out at the pharmacy level, which is why I like to send it to the specialty pharmacy to make certain the patient gets what we prescribed.
Yeah. I found that too. Okay. Here, I'll read the next one as well. So when does one consider PRP plasma serum drops? So this is probably the autologous serum eye drops. Yeah, patients with moderate severe dry eye, patients with autoimmune systemic conditions, when no other dry eye treatments have been effective. So yeah, I think autologous serum eye drops are kind of considered a what do they call it? A third line treatment, or you've tried tears and plugs kind of moved up the dry eye ladder. So that can be, but sometimes you can actually, there's a lot of places that will direct autologous serum drops before that, specifically if you know if someone has neurotrophic keratitis or maybe autoimmune keratitis related things, then I know you can do it way before that. So yeah, what do you think about that?
Yeah, I love autologous serum. It's kind of my secret weapon.
Mhm.
And we do it in our office. We spin down the patient's blood and give them serum to go home with. It has, growth factors, and it does an amazing job of treating inflammation. I kind of start that when my first and second line therapies don't work. First line therapy might be Mibo. I like Zydra. I like Viva. I like all those. And when that's not enough, that's where I go. And it's most commonly used for me in patients who have rheumatoid disease, Sjogren's syndrome, sometimes neurotrophic keratitis, as you mentioned. It's a great drug. And there's a company now that's in FDA trials now to provide a FDA approved drug. Right now, everything is kind of formulated in your office, but there's a company that's probably 2 or 3 years away, but we'll hopefully have that available in the future.
Okay, I didn't know that. Okay, yeah, hopefully that answered the question there. So the other one that we have here, which is more effective, ivermectin cream or oil or oral? Not oil. I actually don't know on this one.
My response is don't use either one.
Okay, yeah,
It's,
okay.
okay. Ivermectin cream or ivermectin oral medication, they are effective against mites, but I don't see any reason to use a systemic disease to treat a local problem. Um, the ivermectin cream can be effective, but not nearly as effective as Xdemvy. So
Yeah.
I just don't I just stopped using all those other medications. The only time I use them is when I have nothing else available. And as I said, my backup plan is tea tree oil.
Okay, yeah, that's what I figured there. Okay, so another question that just came up. Hello, I have patients, females with Sjogren's syndrome. They all have keratitis. Um, I'm guessing it's filamentosa or filamentary keratitis and severe dry eye. How should I proceed to give autologous serum, cyclosporin, or punctal plugs? Probably all of the above. So you could.
That was exactly what I was going to say. That was
Yeah, okay.
well, all of the above. Sometimes I use oral doxycycline with filaments. I find the anti-coagulatic effect of doxycycline can be effective here. But you're right, all of the above. And you got to encourage the patients to blink. A lot of times filaments, because the patient doesn't blink, their eyes are closed. You got to ask them to open their eyes up. But yeah, all those therapies are good. It's a tough disease to treat.
Yeah, yeah, for sure. Okay, and then same person asked, I guess, a follow-up question. Should I remove epithelium or not to touch it, as I do not know how I can heal it? Remove epithelium? Maybe remove the filaments? Is that what we're talking about here?
I would think so. Yeah, that makes sense.
Yeah. Oh, how to remove filaments? Um. Oh, okay. So yeah, should we remove the filaments or just leave them be? I guess that's the question.
It depends whether you like the patient or not. If you don't like the patient, leave the filaments there. But if you if you want to make the patient feel better, yeah, you want to remove them. I'll just put a drop of anesthetic in the eye, and I'll use basically a tying forceps, and I'll just basically pluck them one by one,
Yeah.
and
Okay.
explain to the patient they may be more uncomfortable. So you'll create an epithelial defect at the base of these filaments. So they may be a little more sore afterwards for a few hours, but then they don't get the tugging every time they blink with the filaments. It tugs on their corneal nerves. They'll be markedly improved within a couple of minutes. You can also put a bandage contact lens on for a day or so once you remove the filaments, and that helps too.
Helps to heal up. Yeah, I'm the same way. So I think I have a few patients where they almost come in routinely, it seems like, to get those filaments removed. And yeah. Okay. Oh,
Neil,
another
Neil,
question.
what bandage contact lens do you like?
Um, so I mean, if we're talking like the FDA approved ones, I mean, we're talking it's just the Oasis and is it Night and Day? Is
Mhm.
that right? There's just the two.
Always,
Um,
yeah, I think so.
so yeah, those those are the approved ones. I actually find myself probably rarely using those as the bandage lens. If I'm seeing someone back the next day, then I'll probably put actually a daily contact in there. I've tried a few. I've tried the Infuse, Dailies Total One, AccuView Oasis one day. Um, yeah, I don't know if I have one that I'm just, ooh, this is the best.
Okay,
Which ones? What do you use?
I just listen to you.
Okay, all right. Okay, when is testosterone drops an option for treatment? Uh, Testosterone drops. Would this be for maybe kind of someone that has had hormone changes and maybe looking to target those meibomian glands? Is this kind of what we're leaning towards here?
Yeah, there's not a lot of information on that. That's kind of
Yeah.
experimental right now, and there's no good studies that really document the efficacy. It may have a role, but we've tried hormonal drops for years now, and the trials really haven't been effective. More people use estrogen than testosterone, actually.
Okay.
But um, I haven't used either one of those in 10 years. I'm waiting for some studies to come along that document the efficacy. That's a possibility, but for me, it's on the back burner.
Yeah. Okay. I don't think I've ever even had a patient even try that there. So is albumin drops still RX'd? Albumin drops.
It was never RX.
Okay.
Um, Albumin is just another lubricant that you can use, and it can
Yeah.
be formulated in a compounding pharmacy. Um, Sometimes I use that for like burn patients, but I very rarely use that either.
Okay. Okay, next question. Is it dangerous to put punctal plug in autoimmune diseases as it will collect toxic factors on surface and can worsen the symptoms in patients with arthritis or with other diseases? So, from what I understand with punctal plugs, I mean, there is a conversation you have or what you kind of want to consider if there's kind of a lot of inflammation on the surface of the eyes. And if you do punctal plugs, you can kind of block some of that inflammation on there. Specifically with autoimmune diseases, though, will it collect toxic factors on the surface?
Yeah,
I don't know.
I can respond to that a little bit.
Okay.
My partner Hank Perry and I actually wrote the paper on that, and that is
Okay.
that when you use an external plug, one of the outlying plugs, what happens is you get glycoproteins will deposit on the plug like anything else. You'll
Yeah.
get that deposit, and then bacteria will adhere to it, and you'll get inflammatory factors on it. So a lot of times when you do a external plug, it will create more irritation. You'll get localized rubbing of the plug against the eye. So I almost never use external plugs anymore. I like to use collagen plugs, or I use Lacrofill, or if I have someone with very, very dry eye, I like to do punctal cautery on those
Hmm.
patients. Now,
Okay.
occasionally I will use external plugs, but again, in response to this question, yes, toxic things do adhere to the plug. It creates irritation. It doesn't cause arthritis or anything like that, but you'll get bacteria that are adherent. You'll get inflammatory factors, and sometimes these plugs create irritation and inflammation that's worse not having the plug.
Yeah. Okay. I think we have one more question, and then we've kind of reached our time here, our time slot. So the question is, do you use I'm guessing azithromycin maybe or doxycycline in MGD treatment, and for how long? Yeah, so
Uh,
doxycycline MGD. Yeah, I guess we're talking about like the 50 milligram a day kind of low dose one. Yeah, is it usually usually go 6 weeks there? Is that kind of the run of the
that's
mill
kind
there?
of that's the minimum for me. I kind of go 3 months usually. 6 weeks will start working. It takes a month to start working.
Yeah,
Oral doxycycline. And the biggest mistake people make is they put them on too much. And you're absolutely right, Neil. 50 milligrams a day is exactly right. There's even a 20 milligram pill for people who are very sensitive. But 50 milligrams is my go-to. It's generic, it's cheap, it works very effectively. And I put them on it for usually 3 months. And sometimes I have patients who can't come off of it. I'll leave them on for a year even,
yeah,
long-term purposes. But a lot of patients will say to me, hey, I really don't want to take an oral medication, especially women. Um, they worry about that, especially in childbearing ages. So my backup plan is to use topical azithromycin,
yeah.
both
Okay.
macrolide antibiotics. The topical azithromycin doesn't work as effectively as the oral doxycycline, but it works pretty well. And I'll just put the drop in once a day, and I put it on the patient's fingertips, and I have them rub it into their lid margins once a day. And I have patients on that for years at a time, and it's helpful. Um, but it's kind of my second line therapy, oral doxy being better, but you know, I don't think I'd want to take an oral medication for a long period of time. So I like that therapy as well.
Yeah, makes sense. Okay. Okay, yeah, so that was it for the questions there.
So, let's close up by, first of all, I haven't worked with you before. You are
Yeah,
you are an outstanding speaker. You have a great way of speaking. You have a great rhythm. You had great material. So it was really a privilege to be with you here today. You did a great job.
yeah, you
Um,
too as well. Yeah, it's been great.
Thanks. I want to thank MedNet for providing the support, helping us with the slides. They did an amazing job. And finally, I want to thank our supporter for this. Who was that, Neil?
Oyster Point.
Oyster Point,
Yep,
exactly. I
yep.
want to thank Oyster Point as well. And I hope you all enjoyed this session here. And